Welcome, everyone. I'm Dr. Carmen Pugliafito, and today I have with me Dr. Jay Chhablani of the University of Pittsburgh. Jay, welcome to Retina Synthesis.
Thank you. Thanks for inviting me.
You had an excellent article, which you co-authored with Dr. Giulia Gregori of Italy and Ancona, about polychoroidal vasculopathy, an important topic.
Mhm.
And we'd like to review the key findings of this article and the key diagnostic and treatment challenges that this disorder presents. What is PCV?
Thank you so much for the opportunity to speak to the audience. And I have been following retinal synthesis for quite some time, and I always really enjoyed listening to these snippets which bring the latest in the field. And kudos to you that you are really running the show so well. So when we really talk about PCV, I think a lot of people believe PCV is a different disease. Some people believe PCV is a subtype of wet macular degeneration. Having practiced in India for a long time, I think that PCV, we should rule out PCV in all macular degeneration patients. So PCV is, as the name suggests, polypoidal choroidal vasculopathy. So we believe that there is a polypoidal changes in the choroidal vessels which starts leaking, and these polyps are typically seen on indocyanine green angiography. That makes this test necessary in our patients. There is a different school of thoughts from New York group that there could be, they are also calling this as a type 1 aneurysmal disease, which could be because of the aneurysmal formation in the choroidal vessels. So when in the clinic when do we, I think the more important question is that when do we suspect there is a patient, this patient has PCV? If you are seeing um, any orangish nodule on the clinical exam, or if you are seeing there is a focal elevation of PED, or we used to call it thumb-like projections on OCT, these are the situation when you'll start suspecting your patient has PCV. And nowadays we have a non-invasive imaging criteria which we published with the Asia Pacific group, where we understand that ICG is not available in all the clinics. So what could be non-ICG criteria to diagnose patients with PCV? We can use on fast OCT to give us the diagnosis of PCV. And if your patient is a poor responder to typical anti-VEGF monotherapy, again, you start suspecting that if this patient has PCV. So overall, I think whenever we suspect any elevation of the pigment epithelial or poor response, or typically in African American patients or Asian patients, if you see that the wet macular degeneration is presenting at a very early age, then again, PCV is one more good differential.
So these eyes do not typically have drusen or geographic atrophy. Isn't that correct?
Yes, we believe that if you are seeing a wet AMD without drusen, then you should start suspecting it is PCV. And these patients typically don't progress very fast to GA. However, in the almost a year and a half ago or so, we published cases of we called as pachychoroid macular atrophy. And there was another paper from Japan where they showed pachy-GA, where they pretty much spoke about RP atrophic changes or macular atrophic changes in patients where they have thick choroid. So typically these patients don't lead to GA, but you can still have a long-standing RP damage which can appear as GA.
So polypoidal is frequently bilateral or not?
Yes, polypoidal is typically bilateral. That's why I always recommend doing an ICG at a very early stage of the presentation. And then very typically these lesions will be in the peripapillary area. And then when you look at the fellow eye of the patient, there could be a silent PCV which is existing, which is still not leaking.
But ICG is the gold standard, correct?
I would say yes, ICG is gold standard, at least for me, but I know that a lot of people have reluctance to use ICGA. But that's why we came up with non-ICGA OCT criteria, which will push you to get more invasive testing done, because we understand that getting invasive testing done, especially nowadays, is where physicians as well as the patients are a little reluctant, and we have such good non-invasive testing, so we can suspect or at least early detect these lesions even on non-invasive tests.
But with ICG, you can basically see occlusion of the polyps very readily, correct?
Yes, so there are a lot of studies, particularly from Asia, Everest or Planet studies, where they try to do follow-up ICGA, where people have shown that there is a polyp regression or occlusion of these polyps. I still practice a very conventional way, so I repeat my ICGA very frequently, just because I want to assure that the lesion is completely closed or not.
What about OCT angiography?
OCT angiography has been shown to be effective in identifying the polyp, but unfortunately, because the flow is so fast, that sometimes we may not be able to see it very clearly. However, when you do OCT angio, you will be able to see branching vascular network or the extent of the lesion. You may not be able to see a typical polyp, but you will be able to see the extent of the lesion, which will again guide you in making the right diagnosis and follow-up as well.
What about ethnic predilection for this disease? It's now found in white people as well.
Yes, like I mentioned that, I practiced in India for quite some time. So for me, PCV was very common. And then we typically thought that, this does not happen in white patients. But then I worked with Dr. Kokame as well as from our group. We saw that, even white patients also are having polypoidal lesions. The only challenge I feel is that here we typically try to start the patients on monotherapy, and then we think about PCV at a very late stage in the management. By then, the lesions have already changed the morphology, and the architecture of the choroidal vessel has already changed. So then we tend to miss those lesions. So I think that as a rule, even though it is not that common in white patients, but I would still recommend our physicians practicing in the West to offer ICG at a very early stage of the disease.
So there's been a lot of controversy about the treatment of PCV with photodynamic therapy versus monotherapy. But before we discuss the evidence, let me just ask you a question. In 2026, after you've made the diagnosis of PCV, what's your line of attack?
I knew that this will come at me, and I will probably be giving a very conventional approach to it. Rather, I would say that today, if I have a patient who is coming to me with a massive subretinal hemorrhage, African American, and I suspect PCV, and I get an ICGA done, I see typical lesion, I will start them on monotherapy, just because the blood is so much that we may not be able to achieve good closure even when we do PDT. However, I think the critical part here is to make the correct diagnosis at the beginning and then start the patient on monotherapy. And once the blood starts resolving, then maybe repeat an ICG. And if you see that the polyp are still active, then I will definitely do a PDT just to assure the occlusion of the lesions. I agree that we have such great monotherapy agents nowadays, particularly faricimab, because I particularly like Vabysmo, because I believe that it works more on the choroidal lesions. So Vabysmo will definitely be more effective, but I think that repeating the ICG will help us to understand the polyp closure or not. Because I feel that we are adding up the burden of monotherapy for a long, long time, and if we are delaying the PDT, then we are making these blood vessels more resistant to be effective towards PDT. If we can decide to do PDT at an early stage, then we may be able to control the lesion much better. Even if we continue the anti-VEGF injections, I believe that we will be able to extend the treatment interval. So I'm more of a combination therapy guy, but PDT after a few injections, but much earlier than typically what people think, about 1.5 year afterwards. I do it much sooner.
So how how often do you do PDT in these eyes?
Uh, I have few patients where I have repeated PDT once or twice in a year, and some of them I have repeated at least like once a year or so for a few years. So yes, I do PDT quite frequently, but that definitely brings the role of ICGA, because I'll have to repeat the ICGA to understand the extent of the lesion. And then very interestingly, sometimes you see that the area where you did PDT last time, it worked really well, but the new area has started developing the polyp. Then you treat that particular area.
So describe your PDT technique for us.
If you have made the diagnosis of PCV, then I would say that, the pretty much it is the standard fluence PDT is preferred in these lesions because they do really well with standard fluence. However, the controversy comes that, can you do standard fluence for the subfoveal lesions? So then you will assess the situation that, how big the lesion is. I don't, I'm not against doing the standard fluence even on the subfoveal lesions, but depending upon the amount of blood or amount of elevation, what we are seeing at the foveal area. But typically it is standard fluence covering the whole lesion documented on ICGA and going beyond the borders.
So you're treating the whole lesion, not just the polyps.
Yes, I treat whole lesion.
So sometimes those lesions are rather large, correct?
Yes, and the lesions are large, but we have to understand that these are the lesions which, if you don't treat them now, then eventually they will turn into polyp, which you will again have to start treatment.
Mhm, mhm. Well, this is a challenging disorder and perhaps something that is good to be referred to a center because photodynamic therapy, younger retina specialists haven't had a lot of experience with photodynamic therapy.
True, true.
Typically.
I agree, and this is something which we discuss even for our fellows, because I do around 3 to 4 PDTs a month. Most of them are for my CSR patients. So I try to really teach them. I'll give them hands-on experience. So, at least they are not afraid to do PDT, because I mean, I'm sure that, PDT is not something which they cannot do. It's just that mindset that, oh, I have not done PDT, so I cannot do PDT.
Yeah.
So that's why I give them, I make sure that, they learn, and so they at least that factor is out of their mind.
Yeah, they need to know how to do the infusion, have a good nurse to help them,
Yes.
and a good imaging system, and they need access to the laser.
Yes. Yes. That's one of the challenges. Yeah.
Access to the laser.
Yeah, but now we because we are in an academic center, so we have access,
Yes.
we have the laser, but I think that there are like a new company, Modulite, they are coming up with this per click offer, so they will get the machine to use. So I think, if we have requirement, there will be people who will come and help them. So we should be just knowing that, yeah, this is what I want and this is what I'll get.
Hmm. So, can you comment a little bit about the Everest trial and the Planet trial?
So I think that the Everest and Planet studies were really pivotal in regards to establishing the role of PDT by doing Everest trial where they actually saw the polyp regression. I don't remember the percentage exactly, but they achieved polyp regression significant numbers by PDT. But then came Planet study where, because aflibercept was just getting their feet into the world of PDT, PCV. In that study, they showed that the aflibercept monotherapy caused significant visual acuity benefit as well as polyp inactivation. So then the question came that, do you really want polyp to be regressed, or polyp inactivation is enough? And we did see that, with the aflibercept, we saw significant regression in the PD. We saw significant benefit in PCV cases, but I feel that they still needed multiple injections. And I think then came brolucizumab. I did not had chance to use Bevoyu, but from Asia they responded significant benefit in PCV patients with Beovu, and even in a subgroup of Hawk and Harrier, we saw significant benefit.
Mhm. I urge our listeners to look at the retina physician article and look at the images because the images are important in making the diagnosis.
Yes, and one thing which I know that Julia, she's my star fellow from Italy. She's spending a year research with me, and then the question was, and this images they don't really show the I mean the example which I have showed in that article, patient has 20/20 vision. He came with just some floaters, and I saw a massive subretinal hemorrhage, everything nasal polyps. So this is what I think the listeners should take home, that these are the patients. You may not have a subfoveal lesion, they may not have any subfoveal fluid, and they may still be 20/20, and you can be really sitting next to the time bomb where there is a large polypoidal lesion which is like in the peripapillary area, and they can bleed anytime. So
Yeah.
I think that's a very important fact.
It's so important to make the diagnosis early and one of the points I think of this our dialogue is to have an index of suspicion.
Correct.
If there are no drusen
Yes.
and you've got neovascularization and PED, think of PCV.
Yes. And if you are more keen towards the imaging part, then the thick choroid is also on the OCT can be a very important sign for suspecting PCV.
Well, Jay, thanks a lot for this discussion. It was wonderful. And
Thank you so much.
we hope to get you back on retina synthesis soon.
Thank you so much. Thanks for the opportunity.